and welcome. In this video, your knowledge on HIV will be checked. If you have difficulty, then see the video on HIV and pregnancy in this series, the link for which will be described below. You will be shown a question and then given 12 to 15 seconds to answer the question. After 10 to 15 seconds, the answer will be revealed and read out to you. Please give a feedback if you think that this kind of video is helpful for your learning. The first question is, why does a pregnant woman who is HIV positive require treatment? And the answer is, the main objective of treatment is to prevent perinatal transmission to the baby. The second objective is to reduce the burden of disease on the woman and her family as well as the state. Now let us move on to the second question. If pregnant woman is HIV positive, how can we reduce the risk of transmission to the newborn? The risk of transmission can be decreased by actively treating the mother with antiretroviral drugs to reduce the viral load in the mother. If the mother has a viral load of less than 50 copies, the risk to the baby is minimum. And this load or viral load is the objective of treatment during pregnancy and at the time of labor. In addition, the delivery of the baby should be planned at a time when the mother has the least possible chance of transmitting the infection to the baby. Okay, let's move on to the next question. What are the options for a woman who is HIV positive and now wants to become pregnant? The options are that she should use a barrier method of contraception and try to suppress her viral load before she starts the pregnancy. If she wants to try for pregnancy normally and naturally through natural intercourse, then the couple can be given the time to try for this pregnancy over a 6-month period. During these 6 months, the couple will have normal natural intercourse using condoms except at the time of ovulation. During the period of ovulation, the couple is given 2 chances for trying a pregnancy. In other words, over a 6-month period, the couple will have normal unprotected intercourse for only 12 episodes or 12 times. So if the couple is prepared to take this risk, then they can do so. However, if they do not want to take on this risk, then the alternative option is to have assisted insemination with her partner's semen. In other words, the semen is introduced into the vagina without having direct contact between the husband and the wife. Move on to the next question. What are the options for pregnancy if a husband is HIV positive and his wife is HIV negative? Okay, so the answer is that if the husband is infected, natural conception carries a risk of transmission to the uninfected female, and alternatives to natural conception are the safest options. The husband should have treatment to suppress viral load, and the couple is counseled to identify the risk. It is better if the natural intercourse is not taken on as an option, and semen washing can be considered with appropriate counseling, as it may decrease the HIV genetic material to undetectable levels. After processing and rechecking for residual contamination, the sperms can be used for intrauterine insemination or in vitro fertilization. Even after sperm washing and reduction of viral load in the husband, the risk of HIV transmission to the wife is not eliminated entirely. Another option for the couple is to either adopt a child or use donor sperm for pregnancy. Okay, the next question is, what are the options to achieve pregnancy if the husband and the wife are both HIV positive? So if the husband and the wife are both HIV positive, then they can have unprotected intercourse at any time. However, for the sake of the baby, both partners should attain maximum viral suppression and be screened and treated for genital tract infections before attempting conception. What is the WHO guidance about PrEP in serodiscordant couples? The answer, time starts now. The answer is, these recommendations have been developed specifically to address the daily use of antiretrovirals in HIV uninfected people to prevent getting infection. So if one partner is not infected and the other partner is infected or is unknown and has a high risk behavior and may be infected, then the person who is not infected, how can that person protect himself or herself? They can protect themselves or himself by using PrEP. So the prevention approach is known as pre-exposure prophylaxis, and this recommendation by WHO is for two groups. One is the men and the transgender women who have sex with men, and the other one is the serodiscordant heterosexual couples. That means men and women having sexual intercourse with each other. Next question. What impact does HIV positivity have in a woman if she becomes pregnant? The answer is, pregnancy does not appear to influence the progression of HIV disease. Furthermore, pregnancy does not seem to affect the survival of women infected with HIV. So if a woman becomes pregnant, it doesn't mean that her survival becomes in any way impacted. And a pregnant woman can infect her newborn baby with HIV. This is the most significant fact about pregnancy, and due to which all the treatment and the management is done during pregnancy. Next question. What is the important education for a patient with HIV who wants to become pregnant and have a baby? The answer is, the patient must use family planning once pregnancy is over, and she must be counseled to maintain optimum health status, and she also must understand that she needs to continue to have her treatment regularly and visit the HIV clinic regularly, and she must stop the use of cigarettes, drugs, and not have unprotected intercourse. What is the focus of clinical history in the HIV pregnant patient? The time starts now. The focus is to find out the infectivity in the patient for transmitting HIV to the newborn, and the focus is to find out the state of health of the pregnant woman. So in pregnancy, the initial history should assess the status of the patient's HIV disease, for example, viral load, for example, the amount of CD4 T cell count, and the need for beginning or altering medication. Review of the medical, surgical, gynae history, high-risk habits, and previous obstetric history will also be done to screen for exposure to intimate partner violence and depression, and referral made to mental health services if indicated. What is the focus of physical examination in HIV-positive pregnant patients? The answer is that the focus of physical examination to assess the entire body. Here, only an obstetrical examination will not be performed, but other systems will also be examined. For example, the chest, the abdomen, to see if there are any masses in the abdomen, what is the level of liver enlargement present or not, and also lung examination and heart examination to make sure that there are no signs of pneumonia or any abnormal features in the heart examination. What is the recommendation of screening of all women for HIV? So if you are in a clinic in your own country, then you have to follow the rules of your own country. But the World Health Organization recommends that women who are at increased risk of developing HIV should be screened for HIV when they present. So these are women who are previously who have had a history of drug abuse, or if they have had if they have had contact with sex workers, or if they have any kind of irregular practices, if they have had blood transfusions, then these are women at risk, and these women should be screened. The American College of Obstetricians and Gynecologists, on the other hand, says that all women who come to the antenatal clinic should be screened. And in the United Kingdom, all women who present to the genitourinary medicine clinic or the sexual health clinic or antenatal services or termination of pregnancy services, or who are enrolled in drug dependency programs, or who are enrolled for treatment in tuberculosis clinics, hepatitis B, hepatitis C, and lymphoma should all be screened. In other words, these are all high-risk women. So the next question is, if a woman has pregnancy with HIV, what laboratory investigations need to be done? The time starts now. So the answer is that you will do complete HIV serology for making a complete diagnosis. You will do an HIV PCR for viral load. You will do a complete blood count as well as a blood test for CD4 levels. You will do a lipid profile and liver function test, hepatitis B surface antigen as well as hepatitis C antibody levels, evaluation of opportunistic infectious diseases, tuberculosis testing, sexually transmitted diseases testing, cervical cytology smear, and assays for gonorrhea and chlamydia. So all of these tests are done on the initial visit, but the PCR for viral load as well as the blood test for CD4 as well as other tests which are necessary will be done on a routine basis at regular intervals throughout pregnancy. The next question is, should you vaccinate women who are HIV positive during pregnancy? And the answer will be provided to you after 15 seconds. The answer is that yes, you should vaccinate women when they are pregnant because they are at risk for certain diseases, and the vaccination should be updated, and the vaccinations that are absolutely necessary include influenza, tetanus vaccine, hepatitis A and B vaccines, pneumococcal vaccines. During pregnancy, we avoid live attenuated vaccines, for example, MMR, varicella, and BCG. The next question is, what is the guideline on prenatal diagnostic testing in pregnant women who are HIV positive? In other words, if any antenatal diagnostic test is required, what is the guideline recommendation on that? 15 seconds to answer this question. The answer is that if supposing the patient is pregnant and needs antenatal diagnosis for the fetus, then as long as it is a non-invasive test, you can do that. But an invasive test should be delayed until the HIV viral load has been established. If the HIV viral load is less than 50 HIV RNA copies, then there is a possibility you can do that under retroviral treatment. But if supposing the mother does not have a status of the viral load, or if the viral load is too high and it is absolutely imperative that invasive prenatal testing has to be done, then the woman has to start continuous antiretroviral treatment immediately, and during the cover of this antiretroviral treatment, the invasive testing is done. What about the care of HIV positive patient in labor? Are there any special guidelines for that? So we are not going to talk in detail about the care of HIV positive patient in labor, as there's another video which has been made about the infection control policies and procedures. So basically there are all of these include which start off with hand hygiene, respiratory hygiene, personal protective equipment, etc., etc. Now we come to the next question. What is the management of a pregnant patient if she has spontaneous rupture of membrane before the 34th week of pregnancy? The time for the answer starts now. And the answer is that if there is spontaneous rupture of membrane before 34 weeks of gestation, then the intramuscular steroids can be given to try to hasten the maturation of the fetal lung. But HIV viral load control and levels are extremely important and critical in decision making. Intravenous intrapartum zidovudine infusion would be used for this preterm patient in labor, and a cesarean section is performed immediately if the viral loads are high. Example, if the viral load is more than 1,000 copies of HIV RNA, or between 50 to 1,000, or if the viral load is unknown. The next question is, when is C-section done in a woman who is HIV positive and now she's getting ready to deliver, she's coming to term or just before term? Your time starts now. The answer to this question is that it depends upon the indication for which the C-section is being done. So if the C-section is being done for obstetric indications, it can be performed after 39 weeks, even if the plasma viral load is low. However, if supposing that the C-section is being done because of high plasma viral load, then this kind of section is done at 36 weeks, between 36 and 37 weeks. If there is pre-labor spontaneous rupture of membranes, then in case the viral load is high, then labor cannot be initiated and a C-section is performed. What is the management of an HIV-positive patient if she has spontaneous rupture of membranes? Your time for the answer starts now. And the answer is that if supposing the patient has spontaneous rupture of membrane and her viral load is very low, then we can do an augmentation of labor and try to deliver the patient vaginally. However, if her viral load is high, then you will do an immediate cesarean section. Similarly, if the viral load is even higher, then again, after spontaneous rupture of membranes, an immediate C-section will be performed. So the cutoff point is less than 50 HIV RNA copies per ml is safe. How will you manage a patient with HIV during postpartum period? Your time for the answer starts now. So in the postpartum period, what you will do is that you will suppress lactation for patients who are not breastfeeding by choice or due to a high viral load. Recommend all patients continue their antiretroviral treatment postpartum and assess the patient's mental health and refer for appropriate services. And do pap smear cytology 3 months after delivery. Care of the neonate after delivery. As an obstetrician, what is your responsibility for the care of the neonate once the baby is delivered? Your time for the answer starts now. Okay, the answer to this is that you will use barrier method for precaution for the protection of staff when the baby is being handled after delivery, and use all single-use items which should be used and disposed of with care. The pediatrician should already have been informed, and if present, that is better. And subsequent to delivery, the baby is handed over to the pediatrician for giving treatment for HIV after birth. So please remember that a patient who has HIV can deliver normally vaginally if there are no medical complications, if there are no obstetrical complications, and if she is in good physical health, and if her viral load is low. But in other situations, depending upon the viral load, decisions have to be made for cesarean section. With this, we come to the end of our experimental video. So please subscribe, like, comment, share, and press the bell icon for future publications and for their notification. Thank you and goodbye.